Dr. Sinchana, you can start now.
Okay, sir. Good evening, everyone. I welcome you all to Allergy Forum, a case based discussion platform, which is an initiative of the IAP Allergy and Applied Immunology chapter. And today is the eighth episode, and we are going to discuss an interesting cases on eosinophilic gastrointestinal disorders. I would like to thank Dr. Neeraj Gupta, sir, who has always been supportive for this program, and all the other office bearers as well of IAP Allergy and Applied Immunology chapter, and also the central IAP. So we have today Dr. Ashwant KS, who is an ISPAGAN fellow in pediatric gastroenterology, hepatology, and liver transplant at Medanta, the Medicity, Gurgaon. And to moderate this session, we have Dr. Sailan Kumar Bana, who is an associate consultant in the Department of Pediatric Gastroenterology, Hepatology, and Liver Transplant. He has done his FNB in the same specialty, and he is also currently working in Medanta, the Medicity, Gurgaon. I welcome you both to this forum, and you can begin the session now. Over to you.
Thank you, Dr. Neeraj sir and Dr. Shinjana and all the office bearers of the IIP Respiratory and Allergy chapter and the Central IIP. So the proforma of the this presentation will be Dr. Aswant will be discussing a case. Then I will be carrying forward the discussion of the topic. So over to you, Dr. Aswant.
Thank you. I would like to start the case presentation by thanking IAP Allergy chapter and my teachers, Dr. Nila Mohan, Dr. Shailen Bana. So let's move on to the case. So we have Master X, who's a 5-year-old male child residing from Kashmir, and history was given by mother and was reliable. So he presented to us with the chief complaints of abdominal pain for 1.5 years, intermittent vomiting episodes of 1.5 years, and the history of poor growth. So the abdominal pain was predominantly in the upper middle abdomen, which was intermittent in nature, progressively increased in frequency, which was initially around 1 to 2 episodes per week, later progressed to almost multiple episodes per day. This was moderate to severe in intensity, and this pain aggravated after food intake, and it relieved after intake of anti-acid medications. There was no radiation to any other location. There were history of occasional sleep disturbances with this abdominal pain. The vomiting was non-projectile, non-bilious, and it contained predominantly food particles that is consumed. This was also progressive in nature, which was actually initially a few episodes in the week, later progressed to multiple per day. And there was also a history of occasional retrosternal chest pain present.
So, Dr. Aswant, I would just like to ask few questions on your second slide.
Yes, sir.
So, can you go back to your previous slide? So, you mentioned that the abdominal pain is mostly in the upper mid abdomen. So what are the organs that you are thinking of being getting involved in this case? What can be the source of the pain?
So considering the location, so it could be either stomach, or it can be the transverse colon, or it can be the the left lobe of liver involvement, or can be the mesenteries, or it can be either be sometimes pancreas as well.
Okay. So you told that the pain it used to get aggravated after food intake. So is there any specific food you have tried to elicit which have aggravated the pain?
Sorry, sir, I did not get, sir.
Any specific food intake which has aggravated the pain?
So I meant to ask basically in after intake of any spicy food intake, sir, oily or spicy food intake.
Right, right. Okay, we are good to go.
Shall I move to the next slide?
Yes, sure.
The child did not have any history of any abdominal distension or bloating. There was no history of loose stools or constipation. There was no history of jaundice or loss of appetite. There was no history of headache, blurring of vision, or double vision to rule out any CNS cause of vomiting. No history of poor oral urine output. There was no history of easy fatigability, pica, passage of blood or worm in stool. No history of regurgitation of food, dysphagia, or food impaction. There was no immediate reaction to any of the intake of food items. There was no history of recurrent wheezing episodes, any skin rashes. There was no history of bony pain, recurrent fever, or any bleeding manifestations. So the child was born term by normal vaginal delivery with a birth weight of 2.5 kg, cried immediately after birth, and there was no significant peripartum, I mean natal history. Then immunization was up to age as per national immunization schedule, and his development is also normal for age, and he's currently studying in UKG. So coming to the nutritional history, the child was exclusively breastfed till 4 months of age. Followed by that, complementary feeding was started. His current calorie, there's a deficit of 30% and a 20% deficit in the protein that he consumes, and he does not consume junk food often. So this is the pedigree chart, two generational pedigree chart of the family. So the marked one is the index patient. He's a second born to a non-consanguineous couple. There was no similar history in any of the family members, and they are the family members reside in a house without any overcrowding, and they belong to a socioeconomic class of 3 as per modified Kupusomic class state. And then the child uses boiled water, and the sanitation facility is also good. Coming to the examination, so his temperature was 98 Fahrenheit, heart rate was 85 per minute, respirator was 20, and blood pressure was 95 over 65, which is between 50 to 90 centile. So overall, his general condition and vitals were stable. The child had pallor. There was no icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema, and there were no signs of micronutrient deficiency present. So this is his IAP growth chart showing his weight of 13.8 kg, which is less than third centile, and his height is 94 centimeters, which is also less than third centile, suggesting that the child is having chronic undernutrition.
Okay.
On systemic examination, abdomen inspection, all quadrants were moving equally with respiration. Umbilicus in the midline inverted. There were no scars, sinus, or dilated veins, or any mass seen. The hernial orifices were free. On palpation, it was non-tender, no mass was palpable, and there was no hepatosplenomegaly. Percussion, no flank dullness present. On auscultation, normal bowel sounds were heard. Other systemic examination were grossly normal. So coming to the differentials, so the first possibility that we kept was celiac disease. The points favoring for this diagnosis was the chronic abdominal pain along with failure to thrive and the pallor that he was having. However, the points against were he was not having abdominal distension or bloating, and there was no history of any altered bowel habits in the form of constipation or diarrhea. There were no history of any other autoimmune disease in the index patient or in the any of the family member. The second possibility was GERD, reflex disease. So the points favoring were the occasional retrosternal chest pain and along with the failure to thrive. However, points against was the nocturnal awakening or as such history of regurgitation was not given. The third possibility was chronic gastritis or peptic ulcer disease. Again, the typical location was favoring this diagnosis, and the aggravation after food intake was also point which was favoring this differential. However, the against a point which was not supporting was the atypical age group. And the fourth possibility that we kept was eosinophilic esophagitis or the eosinophilic gastrointestinal disorder. As the points favoring again were the chief complaints of abdominal pain and failure to thrive. However, the points against were there was no history of atopy in the child or in any of the family member. So with these differentials, we have proceeded with the investigations. So the basic routine investigation in the hemogram, there was moderate anemia with the HB of 8.8. Counts as normal, 11,000 for the age group. However, there was an eosinophilic predominance, 12% of eosinophil count with an absolute eosinophil count of 1,300. And the platelet was also slightly increased, 5.4 lakhs. The liver enzymes were normal. IgA was normal for the age group. IgE was elevated, 557 international units per ml. The upper limit was normal, was 69. To rule out celiac, TTG IgA antibody was done, which is also negative. Iron was deficient, 21. HIV was negative. Thyroid profile was also normal. So we had done a stool for occult blood for the anemia, so it was negative. Ultrasound abdomen was done, which is there was no significant abnormality, and food allergy panel was also already done from an outside institute, which is a blood test, which is also negative. So we had proceeded with the skin prick test because of the eosinophilia found in the hemogram. So it showed hypersensitivity to milk, wheat, fish, and mutton. So with these routine investigations, our possibility of eosinophilic gastrointestinal disease was increased. Hence, we proceeded with the upper GI endoscopy, which showed middle esophagus showed there was multiple mucosal plaques were present involving more than 10% of the surface, and then there was ring-like appearances, which is we call as mild trachealization, and then there was intermittent furrowing present in the middle and lower end of esophagus. The stomach showed erythematous lesion in the fundus body and in the antrum. The duodenal bulb and the second part of duodenum was normal. After this, we had actually taken multiple biopsies involving the upper, middle, and lower esophagus and different parts of the body as well as the duodenum. So coming to the histopathology, so on esophageal biopsy, we got findings of hyperplastic esophageal mucosa with increased eosinophils, 25 to 30, 30 eosinophils per high power fill, and few eosinophilic micro abscesses were present. So this is the histopathological image of the esophagus. And coming to the gastric HPE, so there was mucosa was showing mild, acute, and chronic inflammatory infiltrates, predominantly with the eosinophilic inflammates, so which is around 20 to 25 per high power fill, and few eosinophilic cryptitis was also noted. So all these were suggestive of eosinophilic gastrointestinal disease. Initial slide showing eosinophilic esophagitis, and this is eosinophilic gastritis. So hence we have made a diagnosis of eosinophilic esophagitis along with eosinophilic gastritis. So treatment that we had given, initially we had given 4-food elimination diet, eliminating milk, wheat, fish, and egg for 8 weeks. However, the child did not show any clinical or endoscopic improvement. Hence, we have proceeded with the topical steroid fluticasone spray was given along with elimination diet was also continued for a period of 8 weeks. So there was clinical and endoscopic partial response were present. However, on biopsy, this persistent eosinophilia was present. Hence, we have given a trial of oral systemic steroid, which is oral prednisone, was given off for a period of 8 weeks. And after the end of 8 weeks, we had repeated endoscopy, and then so we had actually there's a clinical improvement as well as the endoscopic improvement, and in the biopsy there was eosinophilia of less than 5, so which also showed histopathological improvement. Hence, the systemic steroid were tapered and stopped over the next 4 weeks. However, the topical was continued for 6 months as a maintenance therapy. At 6 months follow-up, the child is maintaining remission, and the child is still under the follow-up with improvement in the growth and no clinical relapse.
Thank you, Dr. Ashwin, for beautiful narrating this case and the treatment regimen which we followed to treat this case. So this case describes the varied presentation of the eosinophilic gastrointestinal disorders, and it emphasizes that the symptoms may be overlapping with the GERD symptoms and other causes of the food impactions and like achalacias and all. So let me carry forward this case discussion to the discussion of the topic proper. So I would like to share my screen. Dr. Aswan, you can stop sharing.
Yes, sir.
So is it visible now?
Yes, it is, sir.
Okay.
Can you make it slideshows?
Is it okay now?
Yes, yes.
Okay. So I'm carrying forward the case discussion by Dr. Aswan. So the topic for the today's discussion is eosinophilic gastrointestinal disorder. The case was already presented by Dr. Aswant, and I'm Dr. Shailen Kumar Vana. I work as an associate consultant in the Department of Pediatric Gastroenterology, Hepatology and Liver Transplantation, Medanta, the Medicity, Gurugram. So, and we pay our respect to our guru, Dr. Neelam Mohan, who is the director of the department and president-elect in the Central IAP. Okay. So, eosinophilic gastrointestinal diseases, these are usually characterized by the dense infiltrates of the eosinophils in the GI tissues, and these are usually caused by the chronic allergic reactions to the various allergens. The allergens might be food allergen, and the allergens might be environmental allergens. This can be eosinophilic esophagitis, like Dr. Aswant described, and it can be eosinophilic gastroenteritis. So the first topic is eosinophilic esophagitis, like I have already described. In eosinophilic esophagitis, that we get usually the chronic inflammatory disease of the esophagus, which is characterized by symptoms of the esophageal dysfunction. And EOE is usually driven by the immune mechanism, most commonly triggered by the food allergens. So earlier, the EOE guidelines, they used to recommend either a 24-hour pH monitoring or a 2-month trial with a high dose of the PPI to rule out GERD before establishing a diagnosis of eosinophilic esophagitis. But subsequently, several studies they came out with the definitive evidence that the GERD and EOE may coexist. So the reason being, in GERD, the esophageal mucosa, they usually get exposed to the acidic environment, which leads to epithelial dysfunction and eosinophilic infiltrates. And in the other way, the dysmotility, which is usually associated with the eosinophilic esophagitis, they can exacerbate the pathologic GERD. So the GERD and EOE may coexist, and the 24-hour pH monitoring or a 2-month trial with a high dose PPI is not recommended nowadays to establish a diagnosis of eosinophilic esophagitis. In fact, there is an entity called PPI responsive eosinophilic esophagitis also, where the eosinophilic esophagitis, the response clinically and histopathologically with a high dose of PPI for a definite duration, which I will be describing later. So these are the risk factors. The risk factors are past history of esophageal atresia, family history of eosinophilic esophagitis, genetic factors like the mutation in the genes which usually synthesize the proteins like filagrins, desmoglins. These are the risk factors, and prevalence of the eosinophilic esophagitis is higher in patients with other diseases like celiac disease, cystic fibrosis, IBDs, and connective tissue disorders. Like I have already described, and I am not going into details of the pathophysiologic mechanisms. The EOE is usually allergen driven, whether it is environment or food allergen. So ultimately, the allergy-driven immunological response is usually Th2 mediated immune response in EOE, which leads to synthesis of different cytokines like interleukin 5, interleukin 13, and eotaxin 3. They usually get overexpressed over the esophageal epithelial mucosa. Simultaneously, there is underexpression of the desmoglins and filagrins are also found. Symptoms are in younger children and infants. The symptoms tend to be more varied and less specific. They can mimic the symptoms of the GERD, like vomiting, epigastric abdominal pain, food refusal. The parents usually complain that the child is not eating in a good rate or eating very slowly, and usually requiring water during the meals, coughing while the feedings, heartburns, and failure to try. Whereas in other children and adolescents, the most common symptoms are usually solid food dysphagia and esophageal food impactions. We use the pediatric EOE symptom score. It has the revised version of the version 2 to clinically monitor the symptoms of the eosinophilic esophagitis. It has usually 4 domains of dysphagia, GERD, nausea and vomiting, and retrosternal or epigastric pain. Upper GI endoscopy with at least 6 biopsies from the upper and lower end of the esophagus are the diagnostic modalities and the gold standard for the diagnosis and follow-up for the eosinophilic esophagitis. And the findings which we get in case of the eosinophilic esophagitis are loss of vascular markings, trachealizations, white plaques, vertical lines, and in more severe cases, we usually get strictures. Histology, a peak eosinophilic count of at least 15 eosinophils per high power field in the esophageal biopsy is highly sensitive and specific cutoff value for the diagnosis of EOE. We get other findings like basal cell hyperplasia, surface concentration of the eosinophils, and eosinophilic microabscesses. These clinical photographs are from an adult patient, and the courtesy is from Dr. Lipika, who is the senior consultant in the department of the GI histopathology in our hospital. So, is there any role of esophageal pH or impedance monitoring in case of the EOE? Yes, there is definitely a role when the endoscopic or histologic findings are inconclusive. If there is a mismatch between the symptoms and histologic treatment response, and in children with suspected EOE with predominant symptoms of the GRD. If there is coexistent unexplained respiratory symptoms that may be due to the concomitant reflux. So in these few cases, we can go for the esophageal pH, 24-hour pH or impedance monitoring. So according to the latest estrogen recommendations, there is very few role of specific IgE testing and other allergy testing to identify the causative food triggers for the EOE because they usually does not reliably predict the triggering antigen in case of the EOE. Atopy patch testing has no place in food allergen testings. There are few other non-invasive biomarkers like eosinophil peroxidase, activated eosinophils, urinary 3 bromotyrosins, interleukin 10. These are few non-invasive method or biomarkers to predict the eosinophilic esophagitis and to predict the treatment response. However, these are presently not recommended in pediatric cases. Now, coming to the management of part of the eosinophilic esophagitis, the first and foremost step is dietary elimination. Uh, the different regions they follow different dietary elimination plans. The most commonly followed plan is six food dietary elimination plan, where the six most common food items like cow's milk, protein, wheat or gluten, egg, soy, peanut, fish, and seafood. These are eliminated from the food of the child. And according to the different studies, the clinical and histological remission is achievable up to 74% of cases. There is a less restrictive four elimination diet where we avoid cow's milk, wheat, eggs, and legumes. These were recently studied in adult populations with EOE and showed a good histological remission rate of approximately 54%. Few other institutes they follow fast food a less restrictive dietary regimens in which the cow milk, wheat containing cereals, and eggs are should be the first food to be considered for the elimination when the implementing step of empirical elimination diet is a bit difficult. So first we should at least restrict these three food items of cow's milk, eggs, and wheat containing cereals. So if there are coexistent multiple food allergies, if the child is having failure to thrive, or if the child is not able to follow the highly restrictive six food elimination diet, then we can go for amino acid formulas. These are highly effective in children with EOE, and they induce the histological remission rate in up to 90% of the patients. Role of the steroid. So steroid is another modality of treatment. In fact, in our patient, we went for oral steroid in our patient because it did not respond to the elimination diet. The most commonly used steroids are viscous budesonide and swallowed fluticasone. The preferred modality is swallowed fluticasone. In the patients with EOE, one point to be highlighted is in the patients with EOE, there are coexistent other allergies and atopies for which the child might be getting other oral steroid also. So while considering the swallowed fluticasone, the total steroid burden should be calculated and considered before initiating the swallowed fluticasone in case of the EOE. Like I have already said, there is an entity called PPI responsive EOE. So PPI therapy has been found to reverse the endoscopic features, typically the fibrotic features like rings and strictures in adult patients. and they have been found to be the histological remission is also found to be of a good rate with high dose of PPI. So in children, the recommended dose of the PPI is 1 to 2 milligram per kg of omeprazole daily, either in a single dose or two divided doses, up to 20 to 40 milligram twice daily. So, what is the ideal treatment of the induction? So, in induction, we can either use the PPIs, elimination diet, or topical steroid, with no evidence of preference to a specific modality of induction. So, we can either use PPIs, elimination diet, and topical steroid. The induction phase should last minimum for 8 to 12 weeks. So after the 8 to 12 weeks, once the patient achieves the histological remission, the maintenance therapy should be continued for at least 1 year. So the point which needs to be highlighted is the management of EOE and other eosinophilic gastroenteritis disorders requires a lot of patience because the maintenance therapy should last at least for a year and may extend up to 2 to 3 years. So during the maintenance therapy, if there is a good clinical and histological remission, we can consider dose reduction of the drugs and we can consider the reintroduction of the food during the maintenance therapy. In case of the refractory cases of the eosinophilic esophagitis, uh, after the KID EOE trial in USA, which was conducted in 2023, dupilumab, which is the anti-interleukin 13 and anti-interleukin 4 receptor antibody, dupilumab is currently FDA approved for the treatment of the refractory eosinophilic esophagitis. Another biologic called as sendakimab, it is presently in phase 3 trial for the refractory EOE. However, the omalizumab, which is the anti-IgE antibody, is not effective in case of the EOE. In case of the severe cases where we get a very narrow stricture, we will have to consider for the esophageal dilatation. But according to the ESPHAGAN guideline, before proceeding for the esophageal dilatation, we may consider short course of the systemic steroid, and if the patient does not respond to the systemic steroid, then we will have to go for the esophageal dilatation. So there are two methods, either a hydrostatic balloon dilatation or Savary-Gillard Bugis. Both the methods are equally effective in case of the esophageal dilatation. So these are the Savary Gillard dilators of different diameters, and this is the fluoroscopic imaging of a patient who underwent dilatation of to 14 millimeter. Right. So this is the summary of the treatment protocol of the EOE, which have been adapted by the SWAGAN in 2023. So once we confirm the diagnosis of eosinophilic esophagitis by biopsy, which shows more than 15 eosinophil per hyper field, we can consider induction therapy, either elimination diet, PPI, or corticosteroids. So after 8 to 12 weeks of the induction therapy, we will have to repeat one biopsy. If the symptoms still persist of the histological remission does not is not achieved, we will have to rethink our diagnosis and consider other possibilities. If the remission is achieved after 12 weeks of the induction therapy, we will have to continue the maintenance therapy for at least a year. So the remission is defined by the three components. There should be improvement in all three domains. That is, there should not be any major symptoms. In histology, there should be less than 15 eosinophil per hyperfield, and EREFS score should be less than or less than 2. So regarding the strictures, like I have already mentioned, we should give a short course steroid of 4 weeks. If the stricture does not respond to the short course steroid, systemic steroid, then we will have to proceed for the esophageal dilatation. These are the drug doses which are recommended for in children for the management of the eosinophilic esophagitis. So now coming to the second topic, that is non-eosinophilic esophagitis, eosinophilic gastrointestinal disorders. So let me start with two cases. We had recently a 6-month-old infant who was presented with generalized edema. He had decreased albumin and IgG level, elevated fecal alpha 1 antitrypsin, which led to diagnosis of the protein-losing enteropathy. We did ascitic trapping, which showed a predominant eosinophils, and we got a clue of serocell involvement of the non-EOE EGID type. We did a duodenal biopsy, which showed eosinophil count of more than 100 per hyperfiltrate. The second case is we also got a 9-month-old kid who presented with 2 months history of weekly episode of the hematemesis. We did an upper GI. We showed multiple aphthous ulcers and linear erythematous lesions in the stomach and duodenum. We did a biopsy from the duodenum which showed eosinophil count of more than 70 for a high power field. We had put the child on extensively hydrolyzed hypoallergic formula and it leads to improvement. So the reason for indicating for describing these two cases are unlike eosinophilic esophagitis, non-eosinophilic gastrointestinal disorders, they have a very varied presentation. The symptoms may overlap with IBD, it may overlap with severe functional abdominal pain. So the symptoms may vary according to the reason of the involvement of the GI tract. If the stomach is involved, that is, if in case of the eosinophilic gastritis, we usually get the patients with symptoms of bleeding manifestations like hematemesis and melena, nausea, vomiting, and recurrent abdominal pain. In case of the small bowel involvement, we get features of the small bowel diarrhea, recurrent abdominal pain, and malabsorptions like we got in our 6-month-old kid. And in case of the eosinophilic colitis, we get symptoms of diarrhea, mucus in the stool, hematochezia, and recurrent abdominal pain. So classification according to the location of the GI tract, it can be eosinophilic gastritis, duodenitis, jejunitis, enteritis, ileitis, and colitis. And based on the GI wall layer involvement, it can be mucosal type, muscular type, serosal type. So most of the EGID are usually mucosal types. So there are three types of the immunological adverse reaction to the food. First is IgE mediated, second is non-IgE mediated, and the third one is mixed type, which is usually eosinophilic mediated. The EGIDs are usually mixed type of food reactions, which are usually eosinophilic mediated. And the point is the EPIs and the EGIDs, they may have overlapping symptoms, but the underlying pathologies behind these two diseases are completely different. One is T cell mediated and one is mixed type, that is eosinophil mediated. So there are the triggering factors might be food allergens. There are concept of leaky guts, and there are evidence of lack of breastfeeding being the triggering factor for the eosinophilic gastrointestinal disorders, which ultimately leads to T helper cell 2 cell activations and overexpression of the eosinophil activating inflammatory cytokines, leading to excessive eosinophils in the GI tissues. Peripheral eosinophilia in like in our previous case, like Dr. Aswant described the case, usually we get peripheral eosinophilia in case of the eosinophilic gastritis, but these are neither specific or not sensitive indicators of this disorder. Fecal calprotectin, it usually measures the intestinal inflammations through the presence of the neutrophils in the stool, which does not directly reflect the eosinophilic inflammation, which is typical of the non-EOE EGITs. So, fecal calprotectin has a role in differentiating between the EGITs from the IBDs. In the IBDs, we usually get elevated fecal calprotectins. Endoscopic findings are usually non-specific. We get mucosal edemas, erythemas, nodules, erosions, and in severe cases, we get bleeding and deep ulcers. In suspected eosinophilic gastritis, we will have to take 8 gastric biopsies. And in case of the duodenitis, we will have to take at least 4 duodenal samples. And if eosinophilic colitis is suspected, we will have to take the biopsies from at least 3 different sites of the colon. So these are the clinical images of a patient with eosinophilic gastritis. Like you can see, there are mucosal erosions and white flakes in the stomach. Histological features, these are clinical features of a patient of a eosinophilic enteritis with lamina propria eosinophilia. And the second one is from the patient with eosinophilic gastritis, where we can see the eosinophilia in the lamina propria and the intraepithelial eosinophilic infiltrates. Courtesy is the same from Dr. Lifika, who is the senior consultant in the Department of GI Histopath. So there are different cutoff ranges according to the region of the intestinal tract to diagnosis to establish the diagnosis of eosinophilic gastrointestinal disorders. In the stomach, the eosinophil count should be at least 30 for high power field. In duodenum, it should be 50. In terminal ileum, it should be 60. In cecum and ascending colon, 100. And transverse descending colon, it should be at least 80. And in the rectosigmoid, it should be at least 60 eosinophils per high power field. So, there are other differentials which should also be considered. I have taken two cases from this journal. So first one was a 12-year-old girl who was diagnosed with cyclic vomiting syndrome, who did not respond to the conventional medication of the cyclic vomiting syndrome, ultimately underwent endoscopy, and eosinophilic gastrointestinal disorder was established on the basis of the high eosinophil counts. The second one is a 15-year-old boy with recurrent gastric and duodenal ulcers with coexistent H. pylori infection who did not respond to the resistant treatment regimen of the H. pylori. Ultimately, the biopsy was revisited in which they found a high eosinophilic count and by the avoidance of the specific foods and steroid, the child responded. So the reason of highlighting these two cases are we will have to consider eosinophilic gastrointestinal disorder in the common GI, other GI disorders, which do not respond to the conventional management. Like the first case is a cyclic vomiting syndrome who did not respond to the treatment, and the second one is a patient with S. pylori who did not respond to the conventional treatment, and ultimately both were diagnosed with eosinophilic gastrointestinal disorders. Management. The first one is dietary elimination. We may follow a elemental diet, a six-food elimination diet, or dietary restriction on the basis of the identified triggers. So there is no solid evidence of supporting the use of food allergy testing as a guideline for the dietary restriction practice in eosinophilic gastroenteritis. And after the clinical and histological goals are achieved, we may also consider the food re-challenge test. So, in case of the severe features, we will have to use the steroids. The prednisolone equivalent of zero point 0.5 to 1 milligram per kg, highest up to 40 milligram should be used for 2 weeks, followed by a reduction over the 2 to 8 weeks if the clinical and histopathological improvement is observed. The second line drugs like immunomodulators like azathioprines and biologics, they may serve as the alternative for reducing the steroid use. However, there are insufficient data to recommend their use specifically for the treatment of non-EOE EGIDs. So to conclude our topic, the EGID is no longer considered as a rare among the children. A high index of suspicion is necessary to facilitate early diagnosis. The diagnosis should be based on the clinical symptoms and histological evidence of eosinophilic inflammation after differentiating from other inflammatory or systemic diseases. It's really essential to maintain a food diary to identify the triggered foods and eliminate them in the long term. Steroids should be considered in case severe cases. Role of azathioprine and biologicals are not clearly established till now. So thank you. I again thank you to the Central IAP and the organizers for giving me this opportunity to cover this topic. Thank you, sir. Over to
Thank you.
Neeraj.
Yes. Neeraj sir, um,
I think it was a wonderful presentation, and both of you, I must say that it was a really very clinically oriented, very practical point steps which you have given. And you have beautifully highlighted about eosinophilic gastrointestinal disorder with a special focus on EOE, and how you mentioned that EOE is basically a mixed type of disorder. Could be IG mediated, could be non-IG mediated, or a mixed pathology. So there is some role of food allergy testing, but negative food allergy testing does not mean that it is not mediated by food or something else. So very important points you have highlighted, and you have also highlighted about the management aspect point of view. So one question which I wanted to ask you, that you rightly mentioned about 6 food elimination diet or 4 food elimination diet, or probably a little less restricted diet. But suppose if a patient improves, as you mentioned, as per the algorithm, and then now there is a time in which reintroduction of the diet is planned. So in which order, which particular food item should be reintroduced? If suppose, for an example, to start with, 3 food items were positive, like milk was positive, egg was positive, and wheat was positive to start with. In a second situation, all everything was negative. So in the first case, based upon the testing, you have avoided. In the second case, empirically you have avoided 3 or 4 food items. So how you should reintroduce, by what gap, what quantity? So please highlight that.
So, sir, if the patient symptom is like of anaphylactic symptoms, then it should be the food item should be restricted for a quite longer period of time, and it should be reintroduced in a hospital setup with a proper anaphylaxis, the facilities for the management of the anaphylaxis. If it is not an immediate hypersensitivity type of reaction, then then we will have to establish which food item usually trigger the disease. So the food items which trigger the disease should be introduced at the last. So,
So yes, I understand what you're saying. The another question is that suppose, for an example, if somebody who has got skin prick test positive for one food
okay.
item or 2 food item, and you eliminated that, and after, let's say, 1 year or 2 year time, now you feel that okay, the disease is under remission and the patient seems to be okay. So would you like to directly reintroduce, or would you like to check with the skin prick test once again, because previously it was positive, and you want to now be, you can say, like, more safer? So if suppose if it is positive, then you probably would like to wait for some more time, or if it is negative, then you would like to introduce, or there is no need in the follow up of a allergy testing, and you would directly like to introduce, irrespective of the results.
Sir, we would like to have your expert opinion in this field, sir, because you are the most expert and god in this field. So we will really like to get this question answered by you,
So
sir.
this is actually means like in a case of food allergy, typical food allergy. So in typical food allergy, how we usually proceed. So suppose in a IG mediated food allergies, whenever a patient we are diagnosing with based upon the history and based upon the testing, and then we are asking them to eliminate, and now the patient seems to have improved their symptoms, and depending upon the natural history of that particular food item, like we understand, for an example, milk, egg, so wheat, these are usually the transient allergens. These, their effect do not remain persistent. For an example, milk allergies usually start in early infancy, and then the people usually, or the children usually, get over by somewhere around 4 years or 5 years of age. So we understand that the natural history of resolution is somewhere around approximately 4 years of age.
Oh,
So what
yes.
we usually do in a typical case of food allergy, somewhere around 3 years of age, we once again test the child. Whatsoever test it was positive earlier, suppose if it was skin prick test or it was specific IgE, we once again test the child. If the numbers are, you can say, like, very much reduced, now they are controlled, then at that particular time we go with a gradual oral food challenge test. If suppose the test is still high, the numbers are still high, we would like to wait for some more time, give it another 6 months time, call them back, and then once again recheck the test. Now there is another component which is there nowadays. There is a concept of component testing. In the component
Okay.
testing, there are certain components of, especially the milk and egg, in which the protein component could be heat labile, and you can say, like, more safer to reintroduce as compared to heat stable, which is not that safer to reintroduce. For an example, in milk, the heat labile components are like lactalbumin, lactglobulin, whereas the heat stable one is the casein. So suppose if somebody who is coming positive to casein, which is heat stable, so we understand that means any formulation of milk he is less likely to tolerate. On the other hand, if it is heat labile, then at that particular time, we would probably like to start reintroducing with the baked milk product rather than the direct milk product with the baked milk product, because by baking the heat labile protein, the structure will be changed and ultimately the allergenicity will reduce. So what we usually do as an allergy specialist, that if the test is positive to start with, IG mediated, we try to follow up this patient with the same test in subsequent follow-up. And when the test is guiding us that okay, now the test numbers are starting reducing or the reaction is started reducing, clinically the patient is stable, then we try to reintroduce. But the problem is there if it is non-IgE mediated. And in non-IgE mediated, actually many times we feel that the diagnosis also is, you can say, like based upon elimination and the re-challenge. So we have to just give re-challenge and then see. But I completely agree with you that these challenges needs to be done in a hospital setup where all the emergency facilities are there, and needs to be done with an expert, and simultaneously a multidisciplinary team approach should be there. So it should not be means like only one single person or one single you can say like team is managing. I think different inputs definitely can help. Any questions from your side, Dr. Sanchana?
Yes, I was just I wanted to know about the treatment part. Like normally we were saying that the sprays, like the sprays which we use for asthma itself, the same one the patient has to just swallow the spray
Yes,
instead of holding it.
yes,
And
yes,
there are
yes.
some places where it is written even about slurries which are made. So which according like of budesonide respules or something, or and they can swallow it.
So
So
usually the preferred modality is the fluticasone, and the child has to swallow instead of doing the inhalation.
okay, that is the preferred one.
Yes.
Okay. Another thing, is there any other non-invasive test like which is using a capsule to measure the eosinophils in the
So
secretion?
in capsule endoscopy, we can only visualize. So we can take a biopsy and diagnose. So
Okay.
like I said, the endoscopic findings of eosinophilic gastrointestinal disorders, they may overlap with other disorders of IBDs like and S. pylori. So on the basis of capsule endoscopies, it's very difficult to diagnose yeah, eosinophilic gastrointestinal disorders.
Okay. So it's more of a histopathological is definitely needed
Yes,
to.
yes, 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 of course.
Dr.
Yes.
Silence, one question from my side, and this is the last one, that in means like what is about the long term prognosis as per your center's experience, means like suppose if your center has diagnosed a child at whatsoever age with this EOE, typical case of EOE, you have done the perfect management, the child is also responded, and then what is the long term prognosis, could be like 10 years down the line, 15 years down the line. So whatsoever the follow up you have, the data you have, what is the long term prognosis of this disease?
So the patients they usually fall into two categories, sir. First is the severe categories we who present with esophageal strictures. So in those cases, those cases are managed with a periodic esophageal dilatation in a gap of say 2 to 3 months. They usually require 4 to 5 sessions of the esophageal dilatation, and after that the symptoms usually subside. Esophageal dilatation, inhaled corticosteroids, and food eliminations. So the maintenance therapy, it should be continued at least for 1 to 2 years. And 2 years down the line, most of the patients they are doing well. We have a pool of approximately 20 to 25 eosinophilic gastroenteritis patients with a good follow-up of approximately 20 patients. All of them have responded in a span of, but they took around 1 to 2 years of if the compliance very good. And in the less severe varieties, if the dietary restriction was very compliant along with the inhaled corticosteroid, they usually respond within a year. So.
Right. And majority of the patients you were able to reintroduce the food items, and then there were no complaints reversal back, or the sometimes it revert back also.
So, on an average, reintroduction of the food items, it usually used to happen after 2 years of the management, usually.
And the chances of, you can say, like, once again, recurrence after reintroduction of food?
So there is no head-on trial till date, sir. I have tried to search different literatures, but according to our experience,
Okay,
in which we have reintroduced the food in 10 to 12 patients, they have not reoccurred. The symptoms have not reoccurred.
right. Great. I think wonderful presentation, wonderful discussion also. And I am really thankful for Dr. Ashwant and Dr. Selen, and especially to Dr. Neelamohan ma'am for giving us this very beautiful presentation and very beautiful discussion. Your team is really doing a wonderful job. And thank you so much. And thank you so much, Dr. Sanchana, for moderating such a dynamic panel, dynamic discussion today. So thank you. Thank you so much for everything. Thank you.
Thank you,
Thank you
Dr.
so much,
Sailen. Thank
sir,
you,
Neeraj
Dr.
sir,
Lucy.
and thank you, Dr. Shinchana. Thank you so much for giving us this opportunity, the different forum, and it was really nice.
Thank
And
you.
we
Thank
learned
you,
a
sir.
lot from Neeraj sir.
Thank you. Thank you. Thank you
His
so
Thank you,
his
Neeraj sir.
closing
Thank
remarks
you.
are always awesome.
much. Thank you.
Yes, yes, definitely. We always like to hear from him.
I never miss a single lecturer of Neeraj sir. His closing remarks are really awesome.